Pericarditis. This is now the inflammation of the outer layer of the heart. This is the sac surrounding the heart. So as I described last week, every moving organ, every moving part of your body, to facilitate that movement, that joint, that organ is encased in a connective tissue, some sort of sac to allow for lubrication. So there's fluid movement, okay, no friction, no pain. So this is now the pericardium. So think of it as the equivalent of the pleura, the meninges, the skin, the fascia, the synovium, the scrotum, the peritoneum. Okay, so similar. These are connective tissues. Now, how does the pericardium get infected? There are 4 general causes, although your textbook has a longer list. So chart 24-7 tells you the causes of pericarditis, but the 4 most common causes are, number 1, infectious. So it's either caused by a virus, bacteria, or fungi. Okay, so same causes as with endocarditis. Second, it's also caused by an autoimmune disorder. Now, the autoimmune disorder here is typically lupus. Lupus is a systemic connective tissue disorder, which means any connective tissue in the body can be inflamed when you have lupus. And the pericardium is a connective tissue, so it is affected and therefore can be a cause of pericarditis. Of course, all other connective tissues in lupus will be affected as well. So we'll discuss lupus next semester. Third cause is an MI. Now, MI can trigger pericarditis in one of 2 ways. The first one is when you're having an acute MI, meaning myocardial infarction means you have a heart attack, correct? Meaning part of your heart muscles died. So at the section, so let's say it's the left ventricle, a portion of the left ventricle that died, that suffered a heart attack. The pericardium surrounding that area becomes inflamed and therefore you get pericarditis. Now, there's also another cause, which is still caused by a heart attack. However, this happens 2 weeks after the heart attack, meaning you suffered a heart attack today, you survived. 2 weeks later, you develop pericarditis. If that's the case, if the pericarditis occurs 2 weeks after a heart attack, we call that Dressler syndrome. Dressler spelled as dress, like the one you're wearing dresses, and then L-E-R apostrophe S, that Dressler syndrome. So again, the 4 most common causes of pericarditis are what again? Infectious. Second are lupus. Third, acute MI. And then if it occurs 2 weeks after the MI, we call it Dressler syndrome. Okay, so those are the 4 most common. So what happens when the sac surrounding the heart gets inflamed or when you get pericarditis? This is what's going to happen. Ladies, when you have new shoes, high-heeled shoes, stilettos, are they comfortable the first time you wear them? How long before you break them in? Right, you have to wear them a few times, yeah? So what happens, you just got them today. You just pick them up at the corner, and then the party is tomorrow. Okay, so you're planning to, let's get on the ledge, let's get crazy, and then, so you did that, exactly that. So what happens at the end of the day or the following morning? Which part of your feet?
The soles.
And the heels, right? Yeah. And what do you get there around the heels? What develops there? A blister. Okay. So what caused the blister to form? Okay, the constant rubbing, right? The partying, dancing like this. So it's the same thing here. If the sac surrounding the heart is inflamed, can the heart stop beating? Because it hurts, right? If it's inflamed, you should stop, because if your heels hurt, are you going to continue dancing in those shoes? You'll take them off, right? At the end of the day, and then go get your flip-flops. You won't finish wearing them the rest of the night. here, do you have that choice in the heart and the pericardium? The heart will continue to beat, even if it's painful, correct? So if the heart continues to beat against that inflamed sac surrounding it, what will also form? A blister, okay? So same exact story here. So the patient's manifestations, therefore, will be what? What will be the patient's number one complaint? Pain, okay? The pain will be constant. Okay? Every time the heart beats, it's painful. The pain is described to be pleuritic, meaning it coincides with every heartbeat. So every time the heart pumps or beats, the pain appears. Okay? The pain is only relieved if the patient sits up and leans forward. In this position, when they lean forward like this, the pain gets better. Doesn't go away completely, but the pain gets better. So what caused that is really the pressure is taken off of the inflamed area and the patient feels better. The pain is also relieved when they take an NSAID. Okay, like ibuprofen, Aleve, for instance. Okay, so any NSAID will help relieve the pain. It's worse with inspiration, which makes sense. When you inhale, what happens to the lungs when you inhale? Okay, they expand. So what do they do to the heart? Squeeze the heart, correct? So when the the heart is squeezed by the two lungs, it's squeezing the pericardium, the inflamed pericardium, also up against the muscles of the heart. So what therefore will the patient feel? Extreme pain. Okay, so it's painful during inhalation, feels better after exhalation, and also again leaning forward and sitting upright. So worse with inhalation and also with lying down or turning. It's painful. The sound will be like this, creaky or scratchy friction rub. And on labs, it's an inflammatory process. So there's indicators of inflammation, increased WBC, anemia, elevated ESR, CRP. These are, again, your inflammatory markers. So these two will be elevated. Of course, this will cause shortness of breath because when you're in pain, are you comfortable breathing? No. So you'll tend to take shallow breaths, right? Because deep inhalation causes pain. So patient will take shallow breaths. Now, an emergency can occur here. Remember the blister we were talking about with the heels? Okay. When this fluid around the heart, which normally should be only about 5 to 10 ml for lubrication, when that fluid increases, so think about, imagine your mediastinal cavity, your thoracic cavity. So your heart's here in the middle, and then you have your right lung and the left lung. All these three things share the chest wall, the chest cavity, correct? Can you put anything else in there? Can you put a hammer or a burger or a muffin in there? Is there space? No. So we only have space for the heart and the big vessels, right? The inferior vena cava, superior vena cava, and then the right and left lungs. That's all the space you have. So now, if the fluid around the heart increases, meaning there's a blister now forming, what will happen to the pressure inside the thoracic cavity? It increases. So if the lungs are inflating, squeezing the heart, and the pericardium already contains high amounts of fluid, let's say it's only supposed to be 5 or 10 ml. What if it increases to 50, 100 ml? What happens now to the surface area for the heart? So imagine yourself here, you're the heart, and you're supposed to have only a little bit of fluid around you. Now, all of a sudden, when you develop cardiac tamponade, you have a lot more fluid around you. So what will happen to the amount of blood you can receive? And what happens to the amount of blood that will come out? Okay, so cardiac output will decrease. Venous return also decreases. Okay, so let's look at the manifestations therefore. So just imagine for a moment, that's what's happening. If you have cardiac tamponade, give me 3 manifestations. What will happen to your neck veins? Distended. What will happen to your blood pressure? Because now you have less or more cardiac output. Less cardiac output. So what happens to blood pressure? Decreases. When I listen to your heart sounds, if I put a stethoscope over your chest with all this fluid around your heart, what will I hear? Now, crackles are in the lungs. We're listening to your heart sounds. So how will your S1, S2 sound when I put a stethoscope over it? With all this fluid surrounding it, is it going to be clear? Or is it going to sound like this? It's going to sound muffled because you're hearing fluid, not hearing the actual heartbeat. Does that make sense? So those 3 are what we call the Beck's triad. B-E-C-K. Beck's triad. So those are signs and symptoms of cardiac tamponade. Is this an emergency? Yeah. Your patient will die in a few minutes if we do not drain that fluid out. Are we clear? So what are those 3 manifestations or Beck's triad again? Manifestations of cardiac tamponade? Neck vein distension, muffled heart sounds, hypotension. Okay. Tachycardia, there will be tachycardia, of course, because cardiac output drops, right? Yeah, there will be tachycardia as well. Now, is cardiac tamponade expected or is this a complication? Is cardiac tamponade a sign and symptom of pericarditis or is it a complication? It's a complication, okay? Meaning not everybody will develop, not everyone with pericarditis will develop cardiac tamponade, but can they possibly develop it? Yes. You will not die from pericarditis. You will die from cardiac tamponade. Are we clear? All right. Yeah, eventually, you of course you'll suffer a lot if you have pericarditis. I mean, do you wanna just tough this out, stay at home with all this chest pain every time it beats and every time you take a deep breath? Of course, you're gonna send yourself to the hospital, right? You wanna get comfortable or just shoot yourself. Okay? That's easier. You have a gun. All right, so how do we know you have pericarditis? Okay, so the testing would be, of course, we need the labs, right? So we're gonna draw labs and they will show increased CRP, ESR, increased WBC. Okay. And also, of course, this will depend also on the cause of your pericarditis. What were the four common causes again? Infectious, what else? Lupus, MI, and 2 weeks after an MI. Okay, so of course, those are the most common, right? So in addition to those, for pericarditis itself, manifestation, of course, are the pain, right? The chest pain, I already described the manifestations here. Okay, so those are the patient's complaints. And the findings will be in the labs. Now, diagnostic testing will be, we're gonna do an echocardiogram because there's 2 types of echocardiogram. We have transthoracic, meaning we will just put the probe over your chest wall, just like a regular ultrasound. Put the probe here, look at the picture of your heart. Or to get a bigger or even more clear picture, we'll do a TEE. TEE is still an echo, but this one is transesophageal echocardiogram, meaning instead of putting the probe over your chest, we will put the probe into your throat, down to your esophagus, and then look at the heart from your esophagus. Does that make sense? So therefore, which one is closer? The one over your chest or the one from your esophagus? The one through your esophagus. So that will give us even a bigger picture or a clearer picture of your pericardium. Okay. So once we have that, then we get a definite diagnosis or a CAT scan, for instance. Okay, this is important to see whether or not you're having cardiac tamponade. Okay, or it may not be cardiac tamponade; it may just be pericardial effusion. Meaning the difference between pericardial effusion is the amount and onset. Let me clarify. If it's pericardial effusion, meaning the fluid accumulating within the pericardium develops slowly. Okay? It took days for the fluid to accumulate. Cardiac tamponade took only a few minutes to accumulate. So which one is an emergency? Pericardial effusion or cardiac tamponade? The tamponade is the emergency. Okay, so that's the true life-threatening emergency because it developed really, really fast, okay, within a few minutes. So whenever you have a patient diagnosed with pericarditis, what is your priority assessment? What are you looking for? Manifestations of cardiac tamponade. What are those three again? The Beck's triad? Hypotension, jugular vein distension, and muffled heart sounds. Okay. So whenever you have a pericarditis admission, what are you going to make sure you chart to cover your ass? Did you hear the Beck's triad? Did you see the Beck's triad? Yeah? Or are you gonna chart that you didn't see them during your shift? Yes or no? Which one is life-threatening again? The pericarditis or the cardiac tamponade? It's the cardiac tamponade. Okay. Okay, let's go to management. So management, it depends. What is the cause? Was it infectious? Was it the heart attack or 2 weeks after the heart attack? Or is it lupus? Right? Depends. Management depends. What is causing the pericarditis? If it is caused by infection, either viral, bacterial, or fungal, what do you think will be the treatment? Okay, depends. If it's bacterial, then you give antibiotics. If it's fungal, you give antifungals. With viral, you give antiviral. Okay, that's simple. If it's caused by an MI, you treat the MI. Okay, and then the pericarditis will resolve after the MI. Then same thing for Dressler syndrome. If it's caused by lupus, what do? You treat the lupus. Okay, so since lupus is inflammatory, typically when you have a lupus flare-up and then you have pericarditis because of that, then we give you steroids. Okay, anti-inflammatory. What about the patient's chest pain? The patient's in pain. They don't care about what's causing it. They're just concerned about, oh yeah, thanks for explaining that, but I'm in pain. I'm very uncomfortable. Okay, I'm miserable. So what do we give for the pain? NSAIDs. So it can be any NSAID, ibuprofen, or indomethacin. Steroids, who do you think will receive steroids again? Okay, patients with pericarditis who have lupus, caused by lupus. Okay. You think it's advisable to give steroids if a patient is in for bacterial pericarditis? No. Okay. So not all of these will apply. You see where I'm going? Okay, so the management again depends what is causing the patient's pericarditis. Colchicine can be used. Colchicine is for gout, but somehow it works for pericarditis. Now, let's go back to the pericardial effusion or the cardiac tamponade. If the patient has a significant amount of fluid in the pericardium, we have to drain that. Because otherwise, will cardiac output be normal? No, this patient will die. Patient will not be hemodynamically stable. So if it's big enough to cause symptoms of hypotension, meaning decreasing cardiac output significantly, the doctor will do pericardiocentesis. Let's break this word down. Pericardio means the pericardium. Centesis is the insertion of a needle or catheter to drain fluid. So we have procedures like paracentesis, thoracentesis, and this one, pericardiocentesis. Okay, all of them indicate the first part of the word would be which location. Okay, so thora means the plural. If it's para, it's the peritoneum. This one pericardial, this would be the pericardium. So the doctor will insert a needle to drain that fluid. Now, when is this done? Well, depends. What is happening? Is it pericardial effusion or is it cardiac tamponade? Let's say it's pericardial effusion. So if it's pericardial effusion, how fast did the fluid accumulate again? Quickly or over several days? Over several days. So can we plan this thing? Yes, we can plan this. So we don't have to do it today. Okay, we can say, okay, so the fluid's increasing. Let's do it tomorrow morning. Okay, or let's say, okay, let's do it at, let's say, 8 o'clock tonight. Okay, what if it's pericardial? What if it's cardiac tamponade? Right now. Okay, we need this done now. Okay, call somebody. Okay, how is it done? Unlike in movies when you see people that they make Hollywood movies make medical procedures very dramatic, right? Nah, they stab somebody with a needle or something like that. Doesn't happen like that. Okay, so if it's cardiac tamponade, the doctor needs to know how far to insert the needle. Okay, so therefore, do we need ultrasound? Yeah, either fluoroscopy or ultrasound. So they'll call imaging. They come up here. I need to perform a cardiac cardiocentesis immediately. Snap. So come up here right away. So they'll run with the machine. Okay. They'll map out so the doctor knows. Okay, so that's how far the fluid goes. Okay, so I'll insert the needle this far. Okay, so they'll put a betadine over the skin, and then they already map. They know exactly how far to insert the needle, and then they'll insert a 14 gauge, 8-inch long needle, a pericardial needle. They'll insert that, puncture the pericardium, and then drain the fluid. Then you'll see the blood pressure improve, the heart sounds become clear, and then no more jugular vein distension. Okay? Any question about the procedure? So your number one role here is to identify the problem. Okay, so the doctor depends on you, the patient depends on you to identify cardiac tamponade, to identify pericardial effusion. All right? Okay, again, these are all complications, okay, of pericarditis. Pericarditis itself, is it really life-threatening? The pericarditis itself, is it life-threatening? No, it's painful, but it is not life-threatening. What is life-threatening? Cardiac tamponade and or the pericardial effusion. Between the two, which one is the true emergency? Cardiac tamponade. The nursing management here will be related to keeping the patient comfortable. Okay, so give the NSAIDs as needed. Positioning, what's the best position again to relieve pain? Okay, leaning right here, forward leaning or sitting position. Okay. And again, cardiac tamponade. So I know it's in a different chapter, but I already described to you the three. What are those three signs again? Muffled heart sounds, hypotension, and neck vein distension or jugular vein distension. All right, that's it for today.